morning everyone. Myself Dr. Gurigbal Singh. I'm going to talk about venoarterial extracorporeal membrane oxygenation. What is venoarterial ECMO and what are its indication? The most common indications are when there's a failure to wean from CPB, there's a refractory shock caused by MI, or in eCPR. In these cases, ECMO can act as a bridge to recovery, permanent mechanical circulatory support placement, or heart transplantation. Average duration is around 4 to 5 days. So, the indications are many, including MI, ACS, causing cardiogenic shock, or there is various cardiomyopathies, or there is a refractory witnessed cardiac arrest, or primary graft failure after heart transplantation. So there are certain contraindications. The absolute contraindications are aortic insufficiency, aortic dissection, or where there's a low likelihood of cardiac recovery in patients who are not candidates for heart transplantation, or there's end stage renal or hepatic failure, there is a neurological injury incompatible with life, or there is a multi-organ failure with low likelihood of recovery. While relative contraindications are advanced age, inability to tolerate anticoagulation, malignancy which is controlled or in remission, or some anatomical factors precluding cannulation like morbid obesity or severe peripheral arterial disease or prolonged CPR. So what is the physiology of VA ECMO? VA ECMO decreases the native cardiac output and augments total systemic blood flow and oxygen delivery. Mean arterial pressure increases with additional flow through resistance vessels, and LV must overcome this afterload created by arterial flow of ECMO and increased MAP. Decreased preload result in improved myocardial perfusion and reduces stroke work, but additional afterload can impair the LV function and recovery through decreased stroke volume, increase LV ETP, pulmonary edema, and result in hypoxemia and decreased myocardial oxygen delivery. If LV ejection and pulsatility will remain low for prolonged period due to high VA ECMO flows or extremely poor function, patient is at a risk for ventricular or aortic root thrombus and embolic stroke even in the setting of therapeutic anticoagulation. So these are the various types of ECMO. One is through the venoarterial ECMO through peripheral cannulation, another is through the central cannulation, and then there is a VAV ECMO where the oxygenated blood goes into both femoral artery as well as into the venous circulation, as in IJV shown in the third figure. So, what is the ECMO configuration? The venous, which is inflow cannula, and arterial, which is outflow cannula, they are connected in series by a tubing, a pump, a membrane oxygenator with a gas blender. So, clinicians will adjust pump speed, delivered oxygen concentration, and rate of air and oxygen sweep gas flow to help achieve targeted pump flows, PaO2 and CO2 clearance respectively. Circuit components will include flow monitors, pressure monitors, heat exchanger and sampling port. Arterial outflow can be achieved using ascending aorta or subclavian or axillary artery, while venous cannulation typically is femoral or internal jugular vein. So usually they have a centrifugal pump which have higher flows, lower friction and smaller priming volumes compared with roller pump, and currently the default recommendation. While peripheral cannulation will cause fewer cerebral emboli, while central cannulation may confer fewer vascular complications. So the initial settings and goals after implementation of VA ECMO are like circuit flow should be more than 2 liters per minute per meter square, sweep gas flow should be equal to blood flow, FiO2 should be 100%, inlet pressure should be more than 100 mm, oxygen saturation at the outflow cannula should be 100%, while at inflow cannula should be more than 65%, with targeting arterial oxygen saturation more than 95% and mixed venous saturation more than 65%. Arterial CO2 pressure between 35 to 45 mm of Hg and pH 7.35 to 45, and MAP of 60 to 90 with hematocrit of 30 to 40% and targeting APTT 1.5 to 2 times normal and platelet more than 1 lakh. So these are the various configurations like central VA ECMO with inflow cannula into right atrium while outflow into ascending aorta or left atrium. Then there's a pseudo central VA ECMO where inflow is into femoral from femoral or IJV while outflow is into axillary or subclavian artery. While peripheral VA ECMO where the inflow would be coming from femoral or IJV while outflow would be into femoral artery. So there are different LV venting techniques which include pulmonary vein cannula or LV apical cannula or atrial septal puncture with possible LA cannula. Then there are certain percutaneous technique for LV venting during ECMO with using IABP or Impella, which is called EC-Pella. What are the various monitoring techniques which should be used while patient is on ECMO? These are ECG waveform to detect any ectopy or any signs of myocardial ischemia or LV distension which can cause hemodynamic perturbations. Arterial pressure waveform, it will help in assessing the pulsatility of LV and possibly estimating the location of mixing zone. Then monitoring arterial blood sample from 2 locations on separate side of the body. Then temperature monitoring is also important because ECMO has a cooling effect, and even low grade temperature elevation during ECMO may be a sign of infection, and hypothermia may worsen coagulopathy and platelet dysfunction. Then PA catheter can be used, TCD and NIRS monitoring for decreased cerebral perfusion, and frequent echo monitoring is mainstay of treatment, and it enables assessment of biventricular function, aortic valve opening, cannula position, pericardial effusion, pleural effusion and ventricular thrombus formation. So various parameters which we can assess on echo are EF, LVOT, VTI, TAPSE, MAPSE, LVEDT, flattening or paradoxical moment of interventricular septum, RW, MAs, any aortic insufficiency, any valvular disturbances. Then volume status we can assess. So management consideration in VA ECMO is that flow in VA ECMO, it should be equal to pump flow plus native cardiac output. Venous cannula are usually of size 21 to 25 French, while arterial cannulas are between 17 to 21 French, which can provide flow up to 4 to 6 liters per minute. When possible, pump flow should be maintained at less than 80% of the body flow to lessen the risk of stasis and thrombosis in pulmonary vessels or cardiac chamber. Adequate pulmonary blood flow should result in visible pulsatility on arterial and PA pressure monitoring, and insufficient ECMO flow can result in insufficient pump preload, excessive afterload or obstruction in the circuit. Inadequate preload result from intravenous volume depletion, which often manifests as refractory hypotension with increasing vasopressor requirement or suction of cannula called chattering. Decreased preload can also result from pneumothorax, cardiac tamponade or abdominal compartment syndrome. Decreasing the pump speed will relieve the suction while volume status is evaluated and optimized. Then mean arterial pressure will reflect the arterial tone and sum of LV ejection and pump blood flow. The MAP goal represent a balance of adequate systemic, coronary and cerebral perfusion against LV work caused by increased afterload. So assessment of adequate MAP should incorporate perfusion indices such as mixed venous oxygen saturation, arterial lactate, LV pulsatility and clinical and lab evidence of end organ function. MAP goal is usually between 65 to 90 for most of the patients on ECMO. Pump blood flow and MAP may be augmented with vasopressor infusion, judicious fluid boluses, blood product transfusion or a combination of these. In obese or profoundly vasodilated patient, additional venous cannula can increase venous drainage to support adequate blood flow and blood pressure. Hypotension in the setting of low flow should always raise suspicion of possible hemorrhage. Hypotension in the setting of adequate or high flow suggests a decreased SVR and should prompt a workup for infection. Native cardiac output contributes less to MAP that does the VA ECMO flow, but positive inotrope may be beneficial in supporting blood pressure through increasing biventricular contractility and forward flow. This is true during ECMO weaning. Serial transthoracic echo are particularly useful in evaluating cardiac performance under various loading conditions. Now, coming to the oxygenation on VA ECMO, systemic oxygenation is a combination of function of native lung and membrane lung in the circuit. So, ECMO gas exchange occur when venous blood bathes the gas-filled microtubules in membrane oxygenator, and oxygen and CO2 diffuses down their respective concentration gradient. So, CO2 levels are managed by titrating sweep gas flow, while oxygenation depends on FiO2, oxygenator blood flow and exposed surface area. Oxygenation is relatively unaffected by adjustment in the sweep. Air embolism may develop in the membrane lung if sweep gas pressure exceeds membrane lung blood perfusion pressure, and many ECMO circuits are equipped with gas inflow pressure alarms and bubble detectors. In peripheral VA ECMO, lung oxygenated blood is ejected by heart and it mixes the membrane oxygenated blood in thoracic aorta. The location of mixing zone varies according to the balance of flows from LV and arterial cannula. In patient with respiratory insufficiency but relatively preserved cardiac output, the mixing zone may be distal to the left subclavian artery, leading to delivery of poorly oxygenated blood to arch vessels. Isolated cyanosis of upper extremities, head, neck and cerebral or coronary ischemia may develop. Refer to upper body hypoxia or Harlequin or north-south syndrome. This phenomenon is particularly likely in femorally cannulated patient in the setting of cardiac recovery when dose of positive inotropic medication is initiated or increased and during ECMO weaning process. To rule out upper body hypoxia, ABG and pulse oximetry should be performed on right upper extremity or otherwise on the opposite side of mixing zone relative to ECMO circuit's arterial outflow. So, this is a diagram showing Harlequin syndrome where deoxygenated blood is being supplied to the arch vessel causing upper body hypoxia while the lower body is receiving the oxygenated blood from the ECMO circuit. Ventilation, we use lung protective ventilation with tidal volume of 4 to 6 ml per kg with targeting peak inspiratory pressure less than 20-25 cm of water while plateau airway pressure less than 30. Respiratory rate should be targeted around 5 to 10 per minute to help avoid alkalosis and minimize ventilatory induced lung injury. At lower flow, ventilator may need to provide more assistance. PEEP should be provided to optimize oxygenation and prevent atelectasis. Now, pulsatility is a marker of LV contraction and native cardiac output. A lack of pulsatility on waveform signal excessive afterload, minimal LV preload or contractility, and cessation of cyclical opening of aortic valve. This can result in intracardiac or aortic root thrombosis, and a cardiac output of 20% of total flow corresponding to a goal pulse pressure of at least 10 mm of Hg may significantly reduces the risk. So, decreased pulsatility reflects poor LV function or excessive afterload, and LV distension may develop, which can increase wall stress and the risk of increased oxygen demand and impaired recovery. In addition to decreased pulse pressure, sign of LV distension include a dilated and hypokinetic LV on echo, refractory arrhythmias, elevated PCWP and pulmonary edema. Medical intervention to decompress the heart will include positive inotropes, vasodilators and volume removal through aggressive diuresis. Renal replacement therapy may be required to manage hypervolemia. ECMO flows can be decreased to reduce LV afterload or increased to reduce the preload, usually in conjunction with vasodilator. If these techniques do not result in adequate LV pulsatility or if elevated filling, pressure, arrhythmias or pulmonary edema persist, mechanical LV offloading or venting should be performed with the IABP, atrial septostomy, percutaneous VAD such as Impella, or surgical LV venting through an LV apical cannula. This is a diagram showing Impella, which can be helpful in LV offloading. This is a tandem heart through SVC and IVC through atrial puncture going into LA. Anticoagulation monitoring. A bolus of unfractionated heparin of around 40 to 100 units per kg is administered before cannulation with a goal of ACT around 180 to 220. APTT monitoring, it should be 1.8 to 2 times the normal. In case of heparin resistance, we can give FFP or synthetic antithrombin 3. Now complications, bleeding and chattering, the risk is that the patient is on anticoagulation therapy or there is liver dysfunction, DIC. So signs would be there will be decreased ECMO flows, there will be chatter or suction event, there could be oozing from cannulation sites. So we should examine cannulation site, assess pericardial, pleural, abdominal, peritoneal spaces with imaging, get done INR, PTT, hemoglobin, fibrinogen, platelets, consider viscoelastic testing. First sign of bleeding may involve ECMO chatter as a result of relative hypovolemia. During times of very low flow or suction event, hemodynamic instability and hypoxemia can ensue. Immediately decreasing the set flows to 1 to 2 liters per minute can allow for circuit filling until fluids or exogenous blood can be administered. So management is we should decrease anticoagulation, transfuse red blood if there is a bleeding, correct elevated INR and PTT with FFP or PCC, and correct thrombocytopenia and low fibrinogen level with platelet and cryo precipitate, and control the surgical site bleeding if it is there. Hemolysis will present with anemia without sign of bleeding, hematuria, jaundice, elevated LDH and plasma-free HP level. We should get done LDH, plasma-free HP, bilirubin level, examine circuit for clots or obstruction. So for management, we should ensure full anticoagulation if bleeding is not there, transfuse RBCs, decrease ECMO flows or wean ECMO if possible, and consider replacing cannula with large bore. Another complication is clotting or thrombosis. So routine neurological and clinical examination should be done. We should examine the oxygenator membrane and all tubing for fibrin strands with a flashlight. Thin white strands of fibrin are earliest signs of thrombus formation, and they are common around connection sites and stopcocks, and they are benign, and so they do not warrant the circuit exchange or increase anticoagulation dosing, while thrombi will appear as black spot on oxygenator inflow, and those must be monitored. So we should do ABG analysis in that case for both pre-oxygenator and post-oxygenator sample during 100% FiO2, and the post-oxygenator should measure around more than 500. Also, the transmembrane gradient at those two sites should be measured, and it is normally less than 50. High gradient indicate a substantial clot within oxygenator membrane, particularly if pre-membrane pressure is more than 300 and post-membrane pressure is normal. Clots in arterial cannula will also carry high risk of embolization. So these are various complications. There could be hypoxia with PaO2 of less than 60. In these cases, we must ensure pump flow is adequate, that is more than 2/3 of cardiac output. FiO2 and ventilatory FiO2 is 100%. We should optimize mechanical ventilation or consider cooling the patient, transfuse HB if it and target HB around more than 7. North-South syndrome, as we discussed before, if there is a decreased ECMO flows, it has been discussed, there is a chattering or the blood pressure will decrease, there could be bleeding, there could be kinking of cannula, there could be clotting, LV distension or pulmonary edema. So for that we should get done daily chest X-ray or USG, monitor airway pressure, echocardiography to evaluate function of LV, to see aortic valve opening and monitor pulsatility with a goal of pulse pressure more than 10. There could be peripheral limb ischemia, there could be vasoplagia, so we must rule out infections, add vasopressin or norepinephrine, fluid administration, and consider stopping fluid removal. So infection, so broad spectrum antibiotics, source control of infection should be done. This is the two configuration of renal replacement therapy which could be done while the patient is on ECMO. So how to wean the patient from ECMO? Criteria to initiate weaning include ventricular pulsatility on arterial waveform or echo for at least more than 24 hours, MAP of more than 60 in the setting of low dose vasopressor and inotrope, PaO2, FiO2 more than 200 on 21% FiO2 while FiO2 on ventilator is less than 60, it is reasonable to begin to decrease flow by 0.5 liter per minute or 1 liter per minute every 4 to 24 hours, targeting a rate of 2 liters. Before weaning, mechanical ventilation and inotropic support should be optimized. An inhaled pulmonary vasodilator may be initiated in case of RV failure. Volume may need to be removed to aid RV function and optimize respiratory mechanics. While weaning is in progress, pulmonary artery catheter data or lactate and mixed venous oxygen should be seen carefully, and then serial transthoracic echo to evaluate LV function, biventricular function. ABG should be done with the near total pulmonary support being delivered by ventilator. Factors predictive of successful weaning include aortic VTI of at least 10 cm and LVEF of more than 20 to 25% with VA ECMO flow of less than 1.5. If weaning failure is indicated by RV distension and associated decreased LV-EDV. Indication to halt weaning include impaired oxygenation or ventilation, progressive ventricular dilatation, worsening valvulopathy, increased filling pressure, and lack of increase in arterial pulse pressure and marked hypotension. If patient tolerates initial weaning to 2 liters per minute, flow should be decreased to 1 liter under echo guidance. And importantly, full anticoagulation is recommended when titrating ECMO flow to less than 2 liters, and bolus of heparin 25 to 50 units per kg may be administered to prevent thrombus formation. If patient maintains stable hemodynamics and oxygenation and demonstrate adequate cardiac contractility and minimal increase in ventricular distension for 15 to 30 minutes, it is reasonable to return flow to 2 liter per minute and plan for decannulation. So this is the flow chart for ECMO weaning. Thank you.